form's been filled out correctly. Now, GP surgeries, we're obviously aware that referral forms are not a mandatory part of the referral. But because of the mixed team and the fact that we're giving salbutamol during these appointments, we do require a PSD for this. So the referral form is mandatory because we do need that tick box to allow us to give medicine in the clinic when we see these patients, because not everyone is a prescriber that are in these appointments. So that referral comes to our admin team. We just check that that is correct, and then we accept the referral or reject it with advice saying why we need the PSD. And then realistically, the wait is more down to patient choice. So they can freely move their appointments and rebook as they see necessary. So actually, if a GP went to refer today, we could see them as early as Friday at the moment, and that's just partly due to capacity at the moment with a slightly newer service. Sometimes you can't book the same week and it's a week or so in advance, but realistically within a couple of weeks. And then we see them in clinic. The report gets written on the same day and it gets reviewed by the senior team if required, and sent back to the GP directly. So that's using our EPR system, and it comes through DocMan as a letter to the GP. So we've tried to keep it nice and streamlined. As Katie said, the challenges have been with integrating all of those systems, but we're getting there. And even with our current adult service and having known some of those pitfalls, it was still a challenge to get some of those things in place. So just a little quick view of what the referral form looks like. So the majority of this is filled out automatically, we hope, by the GP system, which is what we worked hard to integrate it with Ardens. So it basically pre-populates a lot of these fields based on the patient record. We just have a little bit extra here about child protection, just in case there's anything we need to know on that. But our admin team do also check if there's any information sharing plans active for them. We have a brief reason for referral, so either in here or on the direct ERS service, and then this is the mandatory tick box just here. So we need this PSD in place so that non-prescribers are able to give salbutamol in the appointment, and that's what this tick box is here for, and then the optional pheno test. We have some kind of the standard contraindications for spirometry at the bottom. This is more just a kind of thinking just to make sure that patients aren't being referred with any of these, and we know that a lot of them are very unlikely in the children that we're seeing, but they are kind of fairly standard contraindications for spirometry. What the GP gets back is a lung function report. So we give a summary of the data and we try and organise it nice and cleanly, so you get the best results with percent predicted SR scores and percent predicted change in line with guidelines for reversibility, and some extra information in the pheno result. But we also give a breakdown of the flow volume loops and each individual test that's been provided to make that report, just to give that transparency on reproducibility and exactly what the individual test results showed. And we then also just provide a brief letter just saying it's a direct access service, there's no advice and guidance, we're just providing the diagnostic report. We detail about any relevant medical history, their pheno result, and interpretation of the spirometry and who the test was performed and or reviewed by at the end there. So this is very briefly kind of a bit of a breakdown of who we've seen so far. So since basically December, when we were running these clinics, we've seen about 125 children, young people, mean age about 10, but you can kind of see there's a cluster at the bottom here, and then kind of a fairly even spread through to the teenage years as well. The majority of referrals requested a pheno, and just to kind of, we're capturing some of their salbutamol use, Symbicort use, and just inhaled corticosteroid use. So we ask these questions when they come to clinic, and just looking at what inhalers they're currently on and how long they've been using them for. So about half are using salbutamol. There's a small percentage that do have it but haven't used it in the last 6 months, and about 20-ish% are on Labo ICS, so Symbicort, and another 33% just have the inhaled corticosteroids. So we're looking at Clenel and that type of ICS. We also asked them how long they've been on their inhaled steroids. So we've got a chunk where we couldn't access that information and the patient or parents didn't know, but you can kind of see a breakdown here of those that have been kind of started on it relatively close to when we see them, and those that have been on more long term. And from those referral forms, we also capture how many kind of GP self-reporting that it's prevented a secondary care referral. So pretty decent percentage there in terms of preventing referrals into secondary care. As I said, I'm not going to go through this in any detail for time constraints, but we essentially looked at, for those that are at the KJP conference, this is just a slightly updated version of the post that was presented there, and I'm very happy to share that detail and information with anyone who wants it. But essentially, we perform BDR on every patient referred in, and we were just looking at the percentages that had a positive response, what their phenos looked like, what their baseline spirometry versus post-BD spirometry looked like, and having a little look at essentially how their baseline FEV1 FVC ratio predicts the percentage change in FEV1 post-BD. I appreciate it's a relatively complicated chart to look at when I'm not describing in any detail, so it's more just we have this information, and the bottom line is that realistically using a cutoff of if there's airflow obstruction or not, a baseline is not a very good cutoff for whether we do a BDR response in our children and young people. That's kind of the take-home message from that.
Oh, this is me now, isn't it? So some strengths then. I think definitely a mix of paediatric and physiology staff worked really well. Existing staff skill and respiratory diagnostic clinics certainly made things a lot easier, especially with regards to access to quality teaching and fulfilling competencies of the staff. It was really great that staff were keen to get involved with setting up the service, and that their managers were happy to accommodate us. It's not on the list, but I think we did really well to set up like we did within 5 months of knowing that we were awarded the money. So some challenges then. Yeah, I mean, the biggest challenge was the way the funding worked, that we were given from the ICB, understanding the GP IT systems and underestimating the time it takes to get them set up was probably the biggest hurdle. And at times we're still struggling with this, as we said. Part of the reason is getting communication out to the GP surgeries and making sure that they understand the referral process and the diagnostic pathway. And then finally, the location can be a challenge for some people. Geographically, Andover's like right at the top of Hampshire and not central, and public transport to Andover is not easy. So next steps then. So we're currently looking to provide a skin prick testing service. In the future, we'd also like to think about offering nurse-led history taken assessments, including maybe other measurement tools, and provide inhaler technique checks. Consider providing blood eosinophil testing. We're aware that there are a couple of CDCs in North London that do provide all of these services already. We'd like to do some further audits, and we intend to continue going out and educating our GPs about the service. Thank you. So that's everything. So yeah, if you've got any questions or discussion, feedback.
Amazing. Thank you, Michael and Katie. So I think we've got a couple of questions from this room. If we start off with Steph.
You can't see me. My question is, I know you just said it was on Ardens, but is it available on System 1 as well? Because the way GP surgeries use various systems. So is it on both?
It is.
Yeah, it's on EMIS. It's EMIS actually, isn't it? And System 1. So EMIS in some places and System 1 in other places, yeah.
Yeah, cool. But it's available on all of the GP setups around Hampshire and Isle of Wight. Cool.
Indeed, yes. So we're told.
Perfect. And Professor Connor has got a question.
Thank you. No, it's a great presentation and really good work. It's fantastic and a very valuable service to have here in Hampshire and Isle of Wight. Well done with this. Just a couple of things. when you're clearly you're not providing, you're providing data, objective evidence to support a diagnosis of asthma for GPs to look at and to interpret. I wonder if you might consider in your feedback letter signposting them to the peer website so they can use our diagnostic algorithm. It might be just be quite useful for them then to have a readily available place to go to, which will also then automatically take them to where to go with treatment should the evidence support a diagnosis, or they consider want to give a trial of therapy. So that's just one suggestion that might help integrate what we're doing in Hampshire and Isle of Wight altogether. And then the second thing is, which is slightly controversial, if you've seen our local diagnostic algorithm, it predates the national guidance, and it does not include allergy testing, eosinophils, skin prick testing, and full blood counts. And we do, and that's deliberate. And it's I think it's on the basis of evidence which would suggest that those types of tests do not necessarily recognize children who might well have asthma, particularly in paediatrics, where evidence of atopy is not always present, particularly in younger age groups. So we deliberately don't have that in our local guidance, and we still allow GPs, whilst we're highly supportive and drive the need for objective testing as you're providing, which is absolutely essential. We still give GPs the option to give a trial of therapy if it looks like asthma, despite the negative tests that might sometimes occur. And we know from the case series reported from around the country that there are many children who, on the day of testing, do not necessarily have objective evidence, but they clearly do have asthma from an expert assessment of clinical history and interpretation of how they've been presenting acutely with wheeze over time in the past. So I guess what I'm trying to do is discourage you from going down that pathway and keep the faith with what we're doing locally. Because my worry is the national guidance really doesn't allow you to treat with asthma therapy unless you tick a box. And there are lots of children who will not tick a box, and asking for more boxes to be possibly ticked to get through the line and get treatment is not good practice, in my opinion. I think we should stick with the objective things about what asthma is, which is a disease of the airways with inflammatory markers and with smooth muscle contraction causes alteration in lung function. And the atopy is pretty irrelevant to the disease per se in children and how they might present and need treatment. So that's just it's a slightly biased opinion, but it is the view that we've got approved, regionally across our locality, and is what's led to the creation of our own diagnostic algorithm. So lots of wittering, but there you go. I'll stop.
Yeah, sorry. So we've got a couple of questions on the chat. If we go through them really quickly. So Fiona has asked.
Can I just
Sorry.
answer that first?
Yes,
bit?
Katie,
Just
do.
to say,
Katie, do.
Yeah, absolutely. We'll pop it on the forms. I think that's a really good idea. And just so you know,
thank you.
when I go to do the GP teaching, I definitely do point them towards the peer website then.
Thank you.
Yeah, so I am doing that. And yeah, thank you for your feedback about the skin prick testing. That's given us something to think about.
Yeah.
Thank you.
That's great. Thank you, Katie.
Perfect. Sorry, just two questions. So if a child is using an ICS or combination inhaler, how long would you like them to stop prior to spirometry for diagnosis purposes?
Yeah, I mean, Gary's probably got a better answer than we could provide for this. So
I doubt it.
we generally, obviously the ARTP, which is our respiratory body that we follow for diagnostics, has some washout periods which we follow. It gets tricky when you think about inhaled steroids, especially when we're looking at pheno, because as far as I'm aware, the evidence is not crystal clear on how long that washout period is and how much it will be impacting on the pheno. I know some GP practices kind of go with 4 weeks that they ask them to stop taking inhalers before they come for diagnostics, but that's not the advice that we are giving. So we're not necessarily recommending that they stop all therapy before they come to see us. We're just asking to follow the washout periods on the ARTP and that side.
Yeah, 100%. We should all follow ARTP guidance. Absolutely, absolutely right.
Yeah. So we just say don't take inhalers on the day of testing, knowing that that generally is then 24 hours before, with a couple of other things around spirometry as well. But that's the advice we give on our letters.
Thank you. And I think in the interest of time, we will just move on.
Yeah,
if it's all right, I might send you, if there's any further questions, I will email you guys if that's okay.
Yeah, it's all right, Sam. Something's changed this afternoon, so I can stay on the call, so we can pick up stuff later on or in the chat.
Okay.
I'll respond in the chat as we go through.
Perfect. Thank you very much, Michael. So next up, we've got Nat on breathing pattern disorders. So over to you, Nat.
Yeah, cool. I'll just hopefully share my presentation if it works. We'll see. So hopefully that's just loading now. Cool. I wonder as well if maybe I just hang at the end of the meeting just to, if there are any questions, just so we don't get in the way of Lucy's time too much as well. I'm happy to stay a bit later if people wanted to ask questions after Lucy's talk. But yeah, so just talking a little bit, just a quick overview of dysfunctional breathing, kind of what we look for. So yes, we'll go through a quick trying to define it, a bit of classification. Also sort of how it's clinically identified, and then sort of management from my perspective, from physio perspective, as well as potentially some useful resources if you want to refer back to some of it later down the line. So when we talk about what dysfunctional breathing is, I guess kind of as a bit of an exaggeration, nobody knows, but perhaps more accurately, nobody really agrees on it. Even in some recent consensus studies, not everybody agrees on defining dysfunctional breathing and breathing pattern disorders the same. There's just no sort of one unifying definition or classification protocol that everybody is happy with. A lot of this is down to kind of all the research currently. There's not really many consistencies in the research, how it's diagnosed, population. So some will be focusing on severe asthma, some will be focusing on general asthma, some will be focusing on general population, some will diagnose it with CPET testing, some will diagnose it just with a basic screening tool. So there's just no real consistencies in the research either, which doesn't help. So I guess just kind of generically, a bit more generically, so for the purposes of what the kind of framework I work with, so I kind of see dysfunctional breathing itself as an umbrella term to encompass various, obviously, different causes of difficult breathlessness. It covers different breathing pattern disorders and inducible laryngeal obstruction. And there's kind of this complex relationship between different processes happening and different variations of these for different people. So some might have a much more mechanical or biochemical factor. Some might have more psychological factors as well, and therefore that might sort of change your treatment profiles. So breathing pattern disorders themselves, so it's kind of just inefficient or uncoordinated breathing. I don't know why that's on there twice. Often fast respiratory rate, larger tidal volumes than needed. Often it's sort of associated with poor diaphragmatic use, and it can be noticeable at rest sometimes, but sometimes more prominent when triggered. I probably did have an amazing fourth point for this slide that somehow I edited out, but who knows what that might have been. So what is inducible laryngeal obstruction then? So it's sort of an upper airway dysfunction, normally during the inspiratory phase, and certainly more noticeable during the inspiratory phase. Can cause this kind of stridulous, noisy, inspiratory sound, which interestingly a lot of people, a lot of patients and their parents will refer to this as a wheeze. So if they're describing a wheeze, sometimes it's a bit hard to distinguish that. And there's often some throat pain, discomfort, along with some difficult breathing as well. So kind of one of the distinguishing factors is they feel it a bit higher up than their chest. And this is kind of just a bit of an overview of sort of the last few slides. So dysfunctional breathing at the top, and then you've got branches of breathing pattern disorder, inducible laryngeal obstruction. Then down the breathing pattern disorder line, you've got all the different sub classifications. Annoyingly, hyperventilation syndrome is the only one that is singled out on that framework, but that's just, again, historically the most recognized form of breathing pattern disorder. But there's various other sort of patterns that you might see alongside that as well. And then on the inducible laryngeal obstruction, the previous favorite term was vocal cord dysfunction, but it's kind of more recognized that that's just a subcategory, and there's other sort of supraglottic collapse and other structures around the upper airway that can impact breathing and cause ILO as well. So that's just a nice little overview there. So diagnosing it, BPD is a diagnosis of exclusion. ILO gold standard is nasendoscopy during an attack or when it's been triggered. Rarely happens in practice, and there's no real service for it in the region. So we've referred a couple up to the Brompton, I think, for that if needed. Don't always need it though, really. But we've done a couple of triggered ones here at Southampton as well, but there's no real consistent service here. It's just kind of a bit of an ad hoc thing. So it often relies a lot on screening rather than actually diagnosing it. So some of the screening tools, my Megan questionnaire. So this was created for specifically hyperventilation syndrome, one corner of the framework we're talking about, one corner of the classification. So it's a nice screening tool, but it's certainly not that useful when trying to purely diagnose it. BPAT, which is more on sort of an observational assessment of the patient. There's other tools as well. These are just a couple that I've used most. The general symptom profile is generally perhaps the most useful thing. So getting a nice, good subjective history from the patient is very, very telling generally. And then kind of whenever we're talking about breathing pattern disorder and ILO and dysfunctional breathing, it's often when any known conditions are well controlled, or if there's an absence of any proved conditions as well. So if there's ongoing poor control of say asthma, when they should be well managed, they're adherent to their inhalers, their technique is good, but they're still struggling, then you kind of raising that suspicion. And then you kind of just observe their breathing, and that's kind of quite telling in itself as well often. So just a quick table, we're not going to go through it just for time, but it's there for reference if you are that interested. Sort of some of the key things when I was highlighting some of these, I ended up highlighting the whole table, so then just had to scale it back again. But if their breathing pattern's sort of inspiratory, generally if we're talking about it alongside asthma, that's generally an expiratory issue, more so than inspiratory. Throat tightness, as I said, is quite key for ILO. And then when we're talking about inhalers, so if they don't help, that's quite telling. So they're struggling to breathe, they've got their chest tightness, they take their inhalers, it doesn't help. That's quite telling. If they do help, that's still not necessarily a physiological benefit that they're receiving from that inhaler. So just thinking about that as well. Just because the inhalers do help doesn't mean it's not a breathing pattern disorder or ILO. And as good as the subjective history can be, it obviously often relies on how good the patient and the parent is at reporting symptoms as well. So we'll run through a quick example. We might just rush through this for time as well, but the patient presents with difficult breathlessness. They've got background of asthma and allergic to grass pollen. great adherence to their inhalers, which you've checked. They've got a great inhaler technique, which you've checked. So you start talking to them. They struggle with more intense exercise. It comes on within a few minutes. They get this wheeze. They describe this wheeze. They're not really sure if it's inspiratory or expiratory. They take their inhaler when they're struggling and they recover within a couple of minutes, so then we can carry on. They complain of this chest tightness and difficulty getting a full breath in. And they say they struggle over winter, but also when it's really hot weather. So some of that could align with asthma and allergies, but some of it might not. So then you have a look at their breathing. It's more from the upper chest. Shoulders are elevated. The chest is perhaps a bit overexpanded more than it should do. They're kind of holding a lot of tension in their upper chest. What's happening? Obviously, I'm talking about breathing pattern disorders and ILO, so it's probably a mixture of both of them. We're not quite sure. We're not 100% sure, but they're definitely playing a role. And it may also be exacerbated by asthma or allergies. So even if someone does have this, the asthma and other conditions might actually be a trigger for it to get worse. But hopefully from the questioning, they should be well managed anyway. So treatment, so there's a few key things to do. So make them aware, just making them aware of their breathing pattern can help, educating them a little bit. So even if it's just something simple, like your diaphragm's a bit underactive, that can make your breathing a bit more efficient and help calm you when you're struggling. Doesn't have to be anything major. And then diaphragmatic breathing retraining, so get them nose breathing, engage the diaphragm, practice it. There's some resources on that as well. ILO, if they're still struggling despite diaphragmatic breathing, there's some other exercises you can get. There's an information sheet at the end of the talk presentation. And then obviously you're encouraging an ongoing good management of any known conditions. So here's some links to some of the resources. So this first one, the 2-minute videos, if you click on the link, scroll down, there's just some nice 2-minute videos for technique. Second one, ILO document, little information document from a great website, the same website as the videos. And then also sometimes we use some of the Brompton asthma physio resources, which you may have heard us talk about before. So then sort of next time you see a patient, then I don't know why, but it's not appearing. But yeah, so you're gonna think to yourself 3 quick questions and 3 treatment arms. So what's their medication adherence like, whether it's asthma, allergies, whatever. If they're very adherent, okay. Are they poorly managed? So if they're poorly managed and they're taking all their medications as they should, and they should be managing their known conditions really well, then you're going to have a look at their breathing and do a bit more digging there to see if there's anything you can unpick from their breathing pattern. And then if you suspect it, you can obviously refer to physio and whoever else you might want to. Maybe psychology as well, but you can go through a few things, just make them a bit more aware of their breathing pattern, help educate them a little bit that this actually could be contributing to some of their symptoms. And then a quick bit on diaphragmatic breathing, again, even if it's just giving them some resources to go away and look at. Cool. So that's the end of my talk. I'm happy, as I say, I'm happy if we want to save questions till after Lucy's talk, or whatever's
all right, we'll do that. Brilliant, Thank you, Nats. Yeah, so our next speaker is Lucy, who's going to be talking about psychology in asthma. Over to you.
Hi, I'll just share. So. That working? Yeah, all good. Lovely. So hi everyone. Nice to see lots of people attending today. My name's Lucy. I'm a clinical psychologist based here at Southampton Children's Hospital with the Paediatric Respiratory team. So I'm just going to be talking a bit today about my role and why psychology is relevant to asthma and some ideas about things you might be able to take forward in your work. So I'm based here at the child psychology team at Southampton Hospital. So we have a base in Wordsworth House on site at the hospital. There's about 25 or so psychologists here, and we all work in different specialisms of different health conditions across the hospital. So a psychologist working in health, we try to work at lots of different layers of the system. So we're not just thinking about the child individually, we're thinking about working outwards. But I'll just start by talking a bit about the work that we do with individual children and the type of referrals I get. So I have 2 days a week for asthma here at the hospital, and the type of children that get referred to me are often ones where lots of support is needed around untangling asthma, anxiety, and maybe their breathing pattern. So if physiotherapy hasn't been helpful to distinguish that, and they might be having lots of 999 calls, trips to A&E and things, I can support with helping untangle it a bit more and working with the system to help them kind of calm down, think about strategies that might help rather than instantly using inhalers if we're suspecting that the issue is not asthma every time. I often work with young people that are struggling to adhere to their medication. We also work with thinking about where asthma is really getting in the way of a child attending school or fully engaging in school. Part of my role might be helping the asthma team and the hospital understand a child's neurodivergence or any communication issues that they have, and thinking about how we tailor health services to that child with their communication. And then a really big part of my work is supporting around trauma and when there's been a traumatic experience for a child. So they might have had a really distressing asthma exacerbation or episode, and I do a lot of work with supporting around PTSD symptoms for that. I try and routinely see all children that have been in PICU at the hospital for their asthma. So we try and offer all of those an appointment with me. They don't all accept it, but most seem to want that. And we try to make sure that any child that's being considered for biologics injections are referred to psychology as part of the pathway so that we can kind of screen out whether there's any other issues that might be underlying the ongoing asthma, but also think about their readiness for biologics, and supporting with any issues like needle phobia, things like that. Working outwards in the system, so I'll often be liaising with school, family, the team here at the hospital, and then going a bit bigger, I try and support with wider networks, so things like Talking Today to spread awareness, and then trying to raise more awareness and understanding at a national level. So we have a national Paediatric Psychology Respiratory Significant Interest Group, where we talk about all the cases that we're seeing across the country and we try and share knowledge and resources. As part of that work, we developed some guidelines for provision of paediatric respiratory psychology services in hospitals and health settings across the country. So if you're working in a hospital where you don't have any psychology provision, please have a look at these guidelines because they do give ideas for how you can work with patients, but they also give our guidelines about the level of provision that we feel services should have for psychology. So I think most people that work in health settings hopefully can really understand that psychology and health are completely linked together. And as psychologists working in health, we really feel that the body and the mind are really linked together. They have a very bi-directional relationship. So your health can really impact how you're feeling, and the way that you're feeling can really impact your health. And that's really evident within asthma. So we know that anxiety and depression can be more common in children with asthma. and that in those children that do have anxiety and depression alongside asthma, they find it more difficult to control their asthma. We also know that psychosocial issues can be related to poorer asthma outcomes and can be a significant risk factor. And we also know that some of the treatments that are offered for young people with asthma can exacerbate existing mental health problems, so things like sleep problems, anxiety and depression being linked to higher use of steroids or montelukast as well. Those are just a few examples of how they're linked. There are many different ways that they're linked together. So recognising that not everybody has access to a psychologist, although that would be our wider goal and long-term goal, but we understand that not every health professional has access to a psychologist within your service. I just wanted to think about how you might be able to help any young people that you see thinking about how their asthma and their mental health might be linked. And I completely recognise you already have lots to cover in your appointments. So the first thing that I would say is kind of just being curious. So although a young person might be coming to you for an appointment about their asthma, trying to help them zoom out a bit, and if their asthma suddenly got worse recently or their breathing's become more difficult, just gently exploring whether there's any other triggers externally that are happening, and helping with problem solving any of those factors, and even considering safeguarding where that's appropriate. So we often, when we kind of get cases that have reached a really severe level of asthma, when we go back and kind of plot a timeline, we often find that times where their asthma's got worse are really linked to difficulties happening in the family, so divorce and separation, or even young people being abused. So just being curious about any other factors that might be going on for that family. My dream would be that psychology and mental health is just a routine part of healthcare, and we're always talking about how the brain and the body are linked together, and it's not something that me as a psychologist would be the first person to talk to a young person about. So thinking about the idea of brain-body links, things like the fight, flight, freeze system, can be really helpful to help children understand that you can get chest pains when you're feeling a bit anxious. I think talking about things like when you feel nervous, you get butterflies in your tummy. That's something that lots of children will really understand and will resonate with, but often there's not that wider understanding about that happening in lots of different areas of your body, and your chest can be one of them too. The educational resources like this picture could be helpful, which just show all the different symptoms that you can get. It talks about the body's alarm system being hijacked, but it's just about understanding that the body and the way the body's feeling doesn't happen in isolation of how you're feeling emotionally, and it's not a coincidence that you felt like that on a certain day when you had something really scary happening for you. And again, there's lots of videos on YouTube that can help with this. Another really useful resource is on the Beat Asthma website. So this talks about understanding the difference between asthma attacks and panic attacks, and actually recognizing there's lots and lots of overlap between how an asthma attack feels and a panic attack feels. And I think resources like this are just really useful, because often we find that if the team here at Southampton are the first ones that are ever kind of bringing up the idea of anxiety and asthma being linked, or anxiety and breathing symptoms being linked, they can feel very stigmatized and feel like they're the only person that this idea is being suggested to. And it would be ideal if it was kind of just talked about as a really, really normal part of asthma, that the emotions can be linked. And I think things like this that are from an official website like Beat, and that are emphasising the emotional side and the overlap, are really helpful in destigmatising it. I think often when young people have had a bad asthma episode, or a difficult exacerbation, or even a hospital admission, families can be really scared of talking about it, and they want to kind of gloss over it once it's happened and just focus on the positives. I think kind of reassuring families that they're not going to make it worse by talking about things. It's okay to talk about it with them. And when their child is asking questions, it's okay to answer honestly and to talk it through with them. So in a lot of the trauma work that I do, our kind of building blocks baseline section is just making sense of what happened and helping the child to understand what's happened and what led to that point where they were admitted to hospital or needed to go to the school medical room. So just parents and families can be so helpful in building that understanding with them as a baseline, and it just makes it feel less scary for them if they can see that the adults around them understand what happened and why it happened and what led to it and what's changed now. This in relation to that, this is a information sheet that I developed with Beat Asthma with some of the staff here at Southampton as well. So it's about supporting young people after an acute episode of asthma. And it's just talking about lots of the kind of normal symptoms that happen after a traumatic event. Again, understanding these symptoms and knowing that it's a really normal response to an abnormal situation can be really reassuring to families, because often they have beliefs like, my child's forever changed, these thoughts are going to be stuck in their head forever. They get really worried about the kind of the emotional side of it, and if we can normalize that it's just a normal response to a really scary abnormal situation, that can be really reassuring, and it can help kind of pull them out of it quite quickly, because then they're not worrying about that too much. So this sheet has lots of the symptoms, but it's also talking about things like try not to wrap your child in cotton wool after they've had an asthma episode. And kind of trust the plan, that they've got a really good management plan for their asthma that we know will work. Things like that we found have been really helpful for families after an acute asthma episode. Just something to mention is thinking about parents and carers' well-being. As I said, often after an asthma episode, parents can really kind of clamp down on their child, and out of love and wanting to keep them safe, that can inadvertently make the child feel less safe and less secure. So trying to just notice that and encourage parents to seek help if they are feeling traumatized after seeing their child having an asthma episode or after dealing with it for many years. That can be very helpful and have lots of knock-on benefits for the child once the parent's been able to support themselves about it. Something that comes up really often is about school, and just lots of families don't feel empowered to talk to their child's school about their child's asthma and what they need. So just supporting them to feel empowered to talk about that. That again, Beat Asthma website has some really helpful guidelines around this, and some templates that you can use. In terms of teams, it's really helpful for staff to write letters that can be shared, and just thinking about factors that might come up during the school day for the young person. Supporting young people to think about how they respond to questions from their peers around why are you taking that inhaler, things like that. Sometimes helping them to develop like a little script that they could just use to respond, or even empowering them to say that they don't have to answer questions that their peers are giving. In terms of emotional support within school, most schools will have emotional literacy support assistants, so they're called ELSAs, that you could ask for the child to be referred to just by speaking to the school. And quite a few schools have mental health support teams as well, which are overseen by CAMS, and they offer support within schools for mental health problems. I've just put some links in there, which are some really useful resources. Again, I think any signposting we can do to reassure families that our mental health and our asthma and the way your lungs are feeling are very linked together, to try and take the stigma out of that, can be really helpful for young people. So I'll make sure these links all get shared with you. And I think that's everything for now. I've done a bit of a whistle-stop tour, but yeah, thank you for listening.
Brilliant. Thank you, Lucy. Perfect. So I think that's all our speakers now. So if anyone has got any questions, feel free to ask. I think there's been a few questions in the chat, but the team has been quite good at answering. But if there's anything else, feel free.
Just a quick comment that on our diagnostic pages in the peer guidelines, we've got that hyperlink for the common asthma comorbidities for the physiotherapy for BPD that Matt referred to. So if you're looking for that link to go to those resources for hyperventilation in particular, that's in our guideline.
Send the slides with the links.
Yeah. We will send the resources slides over to everybody. And I guess potentially my question would be potentially for Nat and Lucy. At what point would you refer a child with breathing pattern disorder over to psychology? Is there like a referral threshold?
I guess from my perspective, if I've tried a bit of work with them and it's not working, or it's kind of down to each individual, right? So if they've had a background of potential psychological stuff flaring up, or their asthma symptoms or whatever it might be, then that's probably already going to be a bit more useful than coming to me first. Obviously it's never that straightforward. There's always a mix of things happening, but if there's like a strong psychological background, trauma, a PICU stay, things like that, where there's potential for that to be driving it, then I guess you might think of psychology. There's no harm in those instances talking through some breathing control techniques, but Lucy does some of that anyway. So I guess, if it's clear cut like that, then yes. But if you're not quite sure, and they've come to me and they've tried and we've done a few sessions and I feel like I'm not getting anywhere, or their symptoms aren't changing, then I guess that's perhaps also another consideration. And then you're going back to the history, if there is some of that psychological stuff, even if you didn't think it was that relevant initially, then that might actually be the thing that unpicks it, I guess.
Yeah, I think one thing I would say is that hypothesis of what's driving it having been quite clearly explained by one of you guys first. Because if I'm there trying to explain that there's a potential breathing pattern disorder driving this, they are not going to listen to me. It needs to definitely come from a medic. So I think once you've really got that clear, and it's really helpful to have that written in letters and make sure that the communication has been really clear, that's a really helpful building block. And I can't really do anything until that's done, because otherwise they just still think it's asthma and don't want to don't have motivation to engage with psychological techniques because they don't see the value. But again, if there might be worries about even communicating that with a family. So if you've got worries about that, then that's really appropriate for psychology as well to get involved, but it'd be more alongside in that case. And then I think the other thing that would trump it is if there's kind of loads and loads of 999 calls and A&E visits and just nobody's able to get to the bottom of it, then kind of psychology coming in alongside and helping untangle it all can be really useful too.
Thanks, Lucy. Nat made a very good point in his talk about the fact that for these breathing pattern disorders, often the SABAs, the short active beta agonists, don't work. But the other thing about them is they often cause side effects. So I think it's true to say that if you don't need a bronchodilator, there's another cause for your symptoms, then you're much more likely to get side effects after taking short active beta agonists. And so just simple things like looking for tremor in the hands after SABAs and tachycardia. You don't normally see those things when those drugs are needed for asthma. And if they're being given for another cause of wheezing, then that's a big clue. Go on, Nat.
And yeah, often that kind of makes their breathing pattern work. You know, it feeds into that system, doesn't it?
Yeah.
It feeds into that sympathetic nervous system, which switches things on even more so, which can further sort of be a detriment to your breathing as well.
Yeah.
Okay, and just out of interest, how long is the waiting list for psychology services at the moment?
Not too bad at the moment. It's probably a couple of months. Depends on urgency as well. We'll prioritise some really urgent ones, but yeah, it's normally a couple of months to see cases, which is very different from other mental health services and yeah, other specialisms as well. But yeah.
Brilliant. Thank you very much. Is there any other questions from anyone? And if not, then we will just end the meeting. Thank you again, everyone, for speaking today and for attending. I hope it's been useful. We will be in touch again with the next meeting date. And as mentioned, we will be sending links to the meeting today. Thank you. How do I